At the outset, I would like to thank the organizers for this kind invitation. I bring greetings from Velo. The disclaimer, there is very little data on this topic, IgG4 related autoimmune hepatitis. So bear with me, I'll try and summarize whatever we have. So I'll be concentrating only on the terminologies. There are three terminologies that we need to understand currently. One is IgG4 related disease, IgG4 related autoimmune hepatitis, and IgG4 hepatopathy. So the first term, IgG4 related disease, is a fairly well established term. All of us would be aware of this, and it was first described in 2001. It has a systemic involvement, but there are typical organs that get involved, either synchronously or metachronously, and it has been named by various entities. So histopathology and ISC will be similar of all these diseases, and the usual forms are one of these four forms. It can be HPB involvement, retroperitoneum, head and neck, or Mikulicz or systemic involvement. All of us in this audience would be seeing more of HPB involvement, which anyhow is the most common form of IgG4 related disease. So if you look at what is the typical presentation, it typically presents as autoimmune pancreatitis or sometimes as sclerosing cholangitis. Sometimes you have a serum IgG4 level which can help. We are able to procure a biopsy from pancreas in a percentage of cases if there is a focal lesion, and which is required to rule out CA pancreas as a differential diagnosis. So as I said, HPB involvement is the most common for IgG4 related disease, and almost 20% of these patients with autoimmune pancreatitis have a coexistent biliary involvement, which could be a sclerosing cholangitis or a bile duct compression at the lower end through the pancreas. The most common presentation therefore is painless jaundice, and we all know there are typical imaging findings which can help us diagnose autoimmune pancreatitis. Now I am going to look at the rheumatology criteria for diagnosis. They are it's not a criteria, but they are giving you steps how to go about diagnosing this condition. Now the first step is always a clinical suspicion. So if you have a characteristic clinical finding, a radiological finding, or a pathology which is involving one of the common organs, so once that is met, then only you are going to go into the second. Now the second is one of the most important criteria, which is the exclusion criteria, and they have listed almost 20 exclusion criteria, which I have just tried to put it in a summary form. If you see that the patients very rarely will present with fever, and there is a good response to steroids. So anyhow, if the patient has fever and no response to steroids, think twice before labeling it as IgG4 related disorder. Anything atypical in radiology or pathology, definitely presence of granulomas, giant cells, necrosis, vasculitis, neutrophilic inflammation, all is very atypical for IgG4 related disease. Some of the serological findings, and definitely any other known diagnosis, if there is a coexistent IBD, if there is a malignancy, plasma cell dyscrasia, more likely we are not dealing with IgG4 related disease. Only when we satisfy the exclusion criteria is when the inclusion criteria starts coming in, and that is where we start taking a biopsy and looking for lymphoplasmacytic inflammation with obliterative phlebitis and storiform fibrosis. An IgG4 IgG ratio and an absolute IgG4 cells, which vary with very definitions, can help you in making diagnosis. Now serum IgG4 is elevated in a percentage of patients, but it is not essential that it for a diagnosis. And typical organ involvement is always important. For instance, in pancreas, we know radiology will show diffuse pancreas enlargement with rim and biliary involvement. There are organ specific diagnostic criteria, and I am not going into detail of this. So as Sunil pointed out, the pathogenesis really in IgG4 looks like the B cells are in the center, and when they are exposed to autoantigens is when they sort of develop the cytotoxic T cells, which cause fibrosis and apoptosis and organ damage. At the same instance, they have a class switching of the B cells which become oligoclonal and release IgG4. Whether IgG4 is pathogenic or actually protective is not very clear in the literature. Now, I am not going to go into detail of the treatment, just the basic principles for any autoimmune condition is to reduce the disease activity and prevent irreversible damage. So, to address that, you have to induce remission and maintain remission. Various strategies have been used for IgG4 disease, and maybe a low dose steroid plus minus steroid sparing agents, and rheumatologists would prefer rituximab, as what Dr. Sunil was telling already. In some untreated patients, there may be a metachronous involvement of new organs. Now, we all know that the treatment response depends upon the underlying fibrosis. If there is more fibrosis, less chances of responding to treatment. Now, coming to the second entity, which is really the entity that I was supposed to speaking, is IgG4 autoimmune hepatitis. The data is very, very limited currently. It's the first description was in 2007, was a patient with AIH who had raised serum IgG4 levels, and biopsy showed raised IgG4 plasma cells, and this patient, when followed up for a period of 5 years, developed sclerosing cholangitis. So this was the first description, and then they proposed that this may be a different entity, a subset of autoimmune hepatitis. So what does that mean? That any patient with a diagnostic criteria, with a diagnosis of autoimmune hepatitis, in addition has severe infiltration of IgG4 plasma cells as well as high serum IgG4 levels, can be labeled as IgG4 autoimmune hepatitis. So it's a subset of autoimmune hepatitis. It is not same as IgG4 related disease. And there are only very, very small observational studies, maybe a small case series, and which put a proportion at 3 to 35% of autoimmune hepatitis. So this is the proposed criteria. There is really no consensus on it, so it can be getting modified. So please just have a look. It is, one is definitive diagnosis of autoimmune hepatitis. So we are all convinced it is AIH, and if over and above, if we have a serum IgG4 level of more than 135, which is higher than normal, and the histological liver finding indicating 10 or more IgG4 plasma cells per high power field. In addition, some of the authors or some of the experts have suggested there are specific histological markers like chronic hepatitis with band or bridge-like necrosis, and it will always help if there is a synchronous or metachronous IgG4 related disease in other organs. Now, how is it different from what we already know about classical IAH? Is it worth staining for IgG4 in all patients, or is it going to impact my treatment? Is it going to impact the prognosis? Hardly any data is available, but what we know is the clinical presentation is almost similar, indistinguishable, and the first indication would be just a raised serum IgG4 level. So if we are sending a serum level, you may find it raised, and that can prompt you to search for it. How is the course different? Again, not much data, but looks like the response to treatment is almost similar to any classical AIH, maybe a slightly better in patients with IgG4 related disease, IgG4 related autoimmune hepatitis, but the course remains more or less same as the classical AIH as far as the current studies are going. How does is there any long-term consequences of IgG4 related autoimmune hepatitis? So as I said, the first case at least showed a progression towards sclerosing cholangitis. So that is something that we have to keep in mind. So this is one such study where they looked retrospectively at their cohort of patients who had AIH on biopsy, and over a 12-year period they had around 85 patients, and they sort of retrospectively tried to figure out whether they were IgG4 positive, and they defined it as greater than 10 IgG4 in IgG4 plasma cells per field. Now, when they did this analysis, they found that almost 17% had IgG4 liver expression. And how did they differ from the classical AIH? They may be older, they had more cirrhosis underlying, there was more ductular reaction, which suggests more of biliary sort of injury in patients with IgG4 disease. But the response to treatment seems to be similar in all these patients, in both these subgroups. So we are searching for this disease entity. We haven't found too many patients with fitting into IgG4 related autoimmune hepatitis, but where do we stain for IgG4? We stain for them if the biopsy shows a dense plasma cell infiltration. We stain if there is an unusually high biliary centric damage. So autoimmune hepatitis generally will not have a bile centric damage, but if there is a lot of cholestasis or a ductular reaction, we try and stain for IgG4, and anyhow any patient with we biopsying for small duct PSC or autoimmune cholangiopathie, that is the group we will stain for IgG4. So coming to the last terminology, IgG4 hepatopathy. Now IgG4 hepatopathy, unlike IgG4 autoimmune hepatitis, does not meet the criteria for AIH diagnosis. So there is a mild liver function abnormality. There is a comorbid IgG4 related disease. So you have generally a patient with autoimmune pancreatitis with mild LFT abnormality. You biopsy the liver and there are changes in the liver histology, and that is what is called as IgG4 hepatopathy. So this was a study where they biopsied 17 patients with autoimmune pancreatitis with no obvious cholestatic liver disease, and they found a lot of portal area inflammation, bile duct obstruction, fibrosis in the portal area, hepatic lobule inflammation, and even the bile congestion in the bile canaliculi. So essentially what it means is it's a systemic disease. Liver is getting involved in any patient with IgG4 related disorder. So a bystander effect is called IgG4 hepatopathy. The treatment looks like similar to any other IgG4 related disease and is organ specific to that. So current understanding is if we have autoimmune hepatitis criteria positive but no IgG4 on the biopsy or serum, then it is autoimmune hepatitis. If there is autoimmune hepatitis criteria positive and there is IgG4 in the biopsy and the serum, but no coexistent IgG4 related disease, this is called as IgG4 autoimmune hepatitis, should be treated as classical autoimmune hepatitis currently. Whereas if there is no autoimmune hepatitis criteria positive, but an IgG4 related disease with some liver involvement, this is where we call it as IgG4 hepatopathy. So what is the implication of it? We are not clear about the implication of this, but the question that we would want to ask ourselves is, are we biopsying or do we need to biopsy a lot of patients where we are labeling that as PSC currently? So in this retrospective analysis of 100 patients over a period of 4 years, we had only biopsied 15% or 13% of our patients. So do we need to biopsy more to pick up more of IgG4 related problems, and do these patients respond to steroids? But it's an uncharted territory currently. So I'm going to end with a case. So this is one 43-year-old male patient with chronic pancreatitis who underwent lateral pancreaticojejunostomy in 2007 and now has presented with weight loss and ascites over the last 8 months. And multiple imagings done before coming to our hospital had shown large, more than 10 centimeter liver lesion, which was biopsied twice and did not show any malignancy, but it was shown as an inflammatory lesion. He's off alcohol for 14 years and has pedal edema and ascites. On basic evaluation, if you can look, there was a high gradient ascites, low protein, negative for malignancy, LFT showed very low albumin, and a tumor marker AFP was normal, upper GI showed small varices, and all other etiology of liver disease was negative. An MRI done at our institute also showed a large T2 intense lesion with arterial phase hyperenhancement, possibly cholangiocarcinoma with a high uptake on FDG PET. Now outside biopsy we reviewed, which was negative for malignancy. So our working diagnosis initially was decompensated chronic liver disease. We don't know the etiology, but maybe alcohol and a chronic pancreatitis with lateral pancreaticojejunostomy and a liver SOL which is probably inflammatory. So we went ahead and did a biopsy here, and as you can see, there is a dense portal inflammation. Just 1 minute. There is a dense plasmacytic infiltration and a lot of storiform fibrosis with a high staining IgG. IgG4 was negative, but so we had dense infiltration with IgG staining and no malignancy in the biopsy or no granulomas in the biopsy. IgG4 was more than 400, normal is 135. So it looked like a clear-cut case of IgG4 related liver disease for us, but the rheumatology was not convinced. They said not fitting into the diagnostic criteria. They didn't want to give immunosuppression, definitely not operable with ascites. So we were following him up closely and working up towards alternative diagnosis. But on a short-term follow-up, he came with seizures, and at that time the CSF analysis showed AFB or TB positive. So ultimately it turned out to be a tuberculous lesion, and we started on ATT in this patient. But the patient had undergone 4 biopsies at different centers which did not show TB. So to summarize, IgG4 related disease is based on a diagnostic criteria. Excluding mimics, especially in a country like India, is very, very important aspect of this disease. And liver is often involved either primarily or as a part of systemic inflammatory process. IgG4 related autoimmune hepatitis is currently awaiting a clearer definition, but may progress to sclerosing cholangitis, and IgG4 hepatopathy is to be managed as IgG4 related disease of the primary organ. Thank you.